Parkinson's disease is a degenerative neurologic condition. It's a disease that's progressive. It attacks primarily older individuals, can affect younger ones, and causes them to have slowness, stiffness, shakiness, and unsteadiness in their walking primarily. The other manifestations that we see with that are things like soft, indistinct speech, difficulty walking with shuffling gait, so that they tend to walk and may even propulse forward or tend to fall forwards. They can lose their balance backwards, and so these are the major features of Parkinson's disease. It's caused by a loss in the brain of a specific chemical called dopamine, and dopamine acts as a chemical messenger between nerve cells. And we lose that dopamine because the nerve cells that produce it are dying in Parkinson's at a rate that's much faster than normal.
Are there some signals that caregivers or family members can look for that signal the onset of Parkinson's disease?
There are definite signals of the onset of Parkinson's disease, and they can be very subtle. And they include gradual onset of slowness or stiffness of a hand. That may show up as increasingly small handwriting, a little bit of shaking, and these features typically affect one hand more than the other, so a little bit on one side, a little stiffness on the side, frequently confused with arthritis. People have stiffness. In arthritis, the stiffness is in the joints. In Parkinson's, the stiffness is in the muscles. A little bit more slowness in the walking, and even a little bit more flexion. And that means like the arm is held a little bit more bent up against the body when walking, or the shoulders are held a little bit more forward. That's the typical bent type posture of Parkinson's disease. That's a gradually progressive thing.
Is there any way to slow the progression of Parkinson's once it starts?
Once Parkinson's disease starts now, we have no proven therapy that slows the progression of the disease. There are a number of items we're looking at in research, a number of drugs we're looking at that we've at times thought would slow the progression of the disease, but the findings from those studies really are very ambiguous. So there's no clear way to stop the progression of the disease. There's excellent treatment, however, for the disease. So we can help control the symptoms and help people deal with the symptoms and reduce the symptoms substantially. Lots of treatment, but no cure today.
In a nursing home setting, what suggestions can you give to staff members who care for Parkinson's patients?
A person with Parkinson's may be shaky, and that shakiness may only be manifest when under stress. The shakiness goes away with sleep, and because of those features, some may interpret that as just an indicator of stress. Oh, that person's anxious and nervous, and that's what the shaking is about, when in fact it's Parkinson's disease that's going on. So that's something that can be confused by other people. Also, people with Parkinson's tend to have fewer spontaneous movements, so their face may be held in a fairly stiff mask-like appearance. And that may make people think they're depressed because they don't have the usual animation. Well, people with Parkinson's, in fact, do have a fairly high rate of depression, but you don't know that unless you talk to them. So like everybody else, or the physician dealing with somebody with Parkinson's, or any caregiver, it's important to talk to the patient and find out their feelings. Other problems with the treatment is initially in Parkinson's disease, when the condition is relatively mild, patients respond very well to medication. Their symptoms may be entirely abolished, but as time goes on and the condition worsens, the benefit from medicine can be much less predictable. In other words, there can be a person who has great benefit, can walk very well from their medicine for an hour or 2 hours or even only 30 minutes, and within 1 or 2 minutes be stuck in a chair, unable to work or unable to walk or move at all because their medicine hasn't kicked in. And frequently during those times, people will say, oh, they're stubborn, they're not wanting to cooperate because they just saw them walk, but now they're stuck. And these rapid transitions are a common feature in more advanced Parkinson's. In treating the patient, it's a team approach that's necessary. And for the team approach, and the team includes the physician, the patient's family, and all the caregivers. All components of that team need to be educated. It's critical. The doctor alone can't do it, and especially if the doctor doesn't know about these features too. All people in the team have to be educated. In addition to lack of benefit from the medicine, there are specific side effects from the medicine that can be limiting factors. And these side effects can be For example, jerky, twitchy movements that can occur. So if medicine first kicks in and a patient has relief, say in 30 minutes, their symptoms are reduced, they have less shaking, they're able to move better, they may do fine, and then they may develop sudden twitchy, jerky movements. Their head may go like this, their arms may go like this, and they may have such severe jerky movements that that can knock them over, interfere with their walking, make them lose their balance, and fall. So another observation that's critical is if there are these other involuntary movements, when do they occur with respect to the medicine? How long do they last? And how severe are they? Do they interfere with function? And the severity is another critical part, because just seeing the movements is an important observation, but determining whether those movements interfere with function is critical. Because in Parkinson's, with these involuntary movements that we call dyskinesias is the general term for this, the problem is most commonly told to us by the spouse, because it bothers the spouse a lot of times much more than it bothers the person with Parkinson's. The first thing that's important is patience. And they have to understand that a patient's condition, their ability to move, to even talk, and how fast they can respond can vary dramatically from moment to moment. They need to know that for many of these patients, taking their medicines precisely at the times that it's prescribed is critical. 15 minutes late, that patient may not be able to move at all or open their mouth for 15 minutes because the medicine was late. Making the observations of when can the patient move, how long does the benefit last, when does it wear off, do they get these involuntary, dyskinetic, unusual movements? Those observations that a caregiver can provide are critical for helping us to adjust medicine. There are other complications with medicine that the caregivers can also help us to identify and help us in adjusting medicine. Sometimes medicine can cause difficulties with thinking. Patients can have hallucinations and delusions. This can dramatically affect caregivers when you go in to give a patient their food and they say, there's bugs in the food, and there may not in fact be bugs in the food, but these are the delusions or hallucinations the patients are having. So rather than reacting to it, understanding that's part of the disease or a side effect of the medication is critical. Taking those observations down, reporting them to the physician is very helpful. Another important area for caregiver in Parkinson's patients is constipation. Constipation is a common problem with Parkinson's disease, and a period of severe constipation can make all the symptoms much worse. So a lot of times we don't know how come somebody's worse. It may be just that they've been constipated for several days. Those observations, again, are very helpful. We have a graduated way of treating that. There's a whole series of medicines that can be used or diet adjustments that can help.
How important is training to caregivers and physicians in the care of Parkinson's patients?
People with Parkinson's are very different from other patients that most nursing homes deal with. Now, there are Alzheimer's patients who have difficulty with thinking and memory and don't remember and become confused, and this dementia can happen in Parkinson's too. But what's very different about the Parkinson's patient, even if they have the dementia as well, what's very different is the sudden changes in the condition. The sudden changes in the ability to move, the sudden changes in response to medication. These are what's different. Have compassion for these patients. Don't baby them. Help them to do all the things that they can do, but remember, if they can't, it's not their fault.
Well, sometimes a caregiver who may be caring for a patient doesn't understand that the Parkinson's patient has trouble swallowing. What kind of difficulty does a Parkinson's patient have in simple swallowing?
Right. Swallowing problems actually are a very common difficulty in Parkinson's disease. They can be relatively subtle initially, and that may be when somebody's eating or drinking, they tend to cough a little bit more. And the reason they're coughing, and this is the key question for primary care physicians, is that there's hang up of food or liquid in the throat and it doesn't go completely down into the stomach. Well, not only food and liquid can hang up there, but so can pills, by the way. And so this can be one reason for medicine not kicking in and working, is it's still in the throat, not in the stomach and getting absorbed into the blood system. So that's a problem. It also can cause people to swallow food down the wrong pipe, getting into the lungs and causing pneumonia. In addition, There are swallowing evaluations that can be done by speech pathologists who are expert in this area. And sometimes it's a matter of different maneuvers that can be taught to the patient. And there are various maneuvers that can be done in positioning the head and the neck and the chest when trying to swallow that help the food go down the right pipe and not the wrong pipe. And so the kind of consultation that we can get from a speech pathologist can be absolutely critical for somebody to swallow food, swallow liquids, and have their medicine work properly.
What about falling? How do you prevent falls?
Prevention of falls requires what the problem is with postural instability, and that really is the key. Patients with Parkinson's have particularly difficulty with postural instability when they lean forward or lean backward. That tells us about the conditions that may lead to falls. Walking into a walk-in closet and backing up, that's a place for a fall. Opening a refrigerator door and having to back out, that's a place for a fall. So we try to prevent those situations that require a patient to shift their balance or shift their weight backwards, because they'll tend to fall that way, or walking backwards. Similarly, leaning forwards is the other place that people with Parkinson's can fall. So bending over to pick up an item, that's where a person with Parkinson's can fall. Using a reach or a grabber that an occupational therapist can show these people is a critical adaptive strategy and help prevent falls with people with Parkinson's. Another place that happens, and again this is one that's often thought to be psychological because it happens under these conditions, is going through narrow areas. So walking through a doorway is a place where people with Parkinson's may freeze to the ground, and if they suddenly freeze, they may tend to shift their weight forward. With their postural instability forward, they may tip over and fall at that point. Those conditions are all even made worse by the stress of being in a crowd. Since any stress tends to bring out Parkinsonism, take all those things at a crowd, and there's a real danger of falling there. So one should be cognizant of that problem.
If you're helping a Parkinson's patient rise from a chair or a bed, what do you have to be aware of?
One problem that's common with Parkinson's is what we call orthostasis. And what this is a drop in blood pressure upon arising. And that drop in blood pressure can make somebody feel faint. In fact, it can be sufficiently severe for some people to make them pass out altogether. So waiting a few moments to let the blood pressure equilibrate is very important. So the other key is, if somebody's lying down, first have them sit at the edge of the bed for a minute or two and then come up slowly, or if they're coming from a chair, come up slowly and wait to get their bearings, so to speak. This is a very important part of treatment too, because not only may this occur as part of the disease, many of the medicines we use to treat Parkinson's disease, treat the symptoms, make this drop in blood pressure worse. So this is important for caregivers and others around the patient to know. In fact, a caregiver specifically needs to do something, and what they need to do is measure the blood pressure and the pulse of the patient while they're lying down after they've been down for about 5 minutes, and then after they stand up for 2 or 3 minutes. Blood pressure and pulse.
In summary, what would you say to those who are watching this about the important points to remember?
The key issues with Parkinson's disease, number one, is the symptoms can fluctuate and change rapidly, and they're not under the control of the patient. It's not the patient's fault. Don't blame the patient when they can't get up and move, when they can't get up from the toilet. It's not their fault, it's the disease. Side effects from medication are not the patient's fault. If they're hallucinating and delusional and being irritable, it's not the patient, it's a reflection of the disease or the medication. Make the observations, report the observations. Try to get the timing of the symptoms important with respect to time of day and last dose of medicine. Those observations are going to be critical for adjusting treatment. Have patience with these people. That's very, very important. Try to be understanding. Imagine yourself stuck in molasses, in a full bathtub of molasses and unable to move. That's what it can be like with Parkinson's disease. So those are really the key issues.
There are many different types of communication techniques and also movement strategies that help a person that has Parkinson's disease. The purpose of these is to make it easier for the person that's working with the person with Parkinson's disease, and it also improves the quality of life for that person, and it ensures safety, the best possible safety for the person with Parkinson's disease and also for the staff person. In Parkinson's disease, it's a unique disease, and the symptoms are very unpredictable. So one minute a person might be able to do something, and then maybe a few hours later or the next day they're not able to do that same thing. And a good example of this is when a person's feeding themselves. Maybe in the morning, when their medicine is working, maybe they can feed themselves and maybe later on they can't. Or it might be the opposite. Maybe they can't feed themselves in the morning, but then they can in the afternoon. And so as a person that works with someone with Parkinson's disease, it makes it very difficult because you might think the person's being ornery or they're not being cooperative. But really what it is the person is unable to do that because of the disease. Slowness in thinking may affect how quickly residents with Parkinson's disease will respond to your verbal requests and may determine whether they can express their needs in time. If the residents with Parkinson's disease have difficulty in moving or have rigid limbs, you may feel they are resisting your efforts or your help. And they may also lack the facial expression, which may make you feel they are ignoring you, but in fact, they may just need a few more seconds to act or to speak. Today, we will learn new communication techniques and movement tips to use when working with a resident with Parkinson's disease. These tips will help you to help the resident. Before meeting Sharon and Fred, we would like to discuss communication. Proper communication will help you gain cooperation and participation from your residents. It will also help residents feel better about themselves. For optimal results, make sure if residents use hearing aids, they are working properly. If residents wear glasses, assist them in putting them on. When speaking to a person with Parkinson's disease, speak to them at eye level. Always speak to them at eye level. Most of the residents will probably be sitting down and may be in wheelchairs. Talk directly to the resident and use a normal tone of voice. Remember, they are not hard of hearing. However, their masked expression may make it appear that they do not hear or understand you. Keep requests simple. Ask the resident to do only one thing at a time before moving to the next thing. Keep in mind that some people with Parkinson's disease may need more time to understand your request. Be observant. Residents with Parkinson's disease usually are unable to verbalize their needs promptly. There is a difference between inability to speak and refusing to speak. Remember, allow plenty of time for the residents to respond to you. Frequently, they will show subtle signs of responses, verbally or physically. Always be respectful and treat the person with dignity. Try not to use baby talk, such as sweetie, babe, and honey. Do not talk down to the person, and please be patient with them. This is Sharon, a certified nurse assistant, and Fred, who has had Parkinson's disease for 12 years. Today, Sharon will work with Fred and demonstrate methods of care that will benefit both the resident and staff. A resident with Parkinson's disease is often more rigid in the early morning. This rigidity can be decreased if he has already had his first dose of medicine before getting out of bed. The timing of his medication should be discussed with his physician so he receives the most benefit.
Good morning, Fred.
Sharon sits down to be at Fred's level.
How are you this morning? Are you ready to get up?
It is important to be observant and to be patient. Fred rolled his eyes to her to show that he has heard her, but he has difficulty talking.
Can I help you get up now?
Sharon made simple requests and waited for Fred to respond. She also tried to arrange the bedside rails, which gave Fred a good visual cue to begin his morning routine.
Yeah, I'm hungry.
We have talked about several communication techniques. Speak to them at eye level, use normal tone of voice, keep requests simple, be observant, allow time for responses, and always be respectful. Don't forget, a person with Parkinson's disease is going to have slowness in thinking and difficulty in moving. And when I talk about difficulty in moving, I mean the person will have rigid limbs. They may be resistant when you try to move them, but it's not because they're not putting the effort into it. It's because it's one of the symptoms. Some other problems that you may see with a person that has Parkinson's disease is that it's going to be difficult for them to walk continuously. They may tend to freeze, and also the person is going to have trouble starting a movement, and they may lose their balance and fall forward. And these techniques that we're going to show you today are going to help you to help that person move better. And if you use them on a regular and consistent basis, it will indeed make life for the resident and for yourself much easier. It is important to learn and use these movement tips on a routine basis. Communicate before any movements. Always tell the person with Parkinson's disease what you are going to do with them, for them, and the direction of the movement. Allow time in between position changes so that residents can adjust their bodies, for example, sitting to standing, lying to sitting. Always use a gait belt when lifting or transferring a resident. Set up the placement of their bodies and limbs so they will be able to safely do as much as possible for themselves. Set up the environment and let them safely do as much as possible for themselves. Allow extra time to perform a task, but make sure you frequently check on their needs. Distract residents when they freeze in doorways, narrow paths, or in a small or dark room. Always tell the person with Parkinson's disease what you are going to do with them, for them, and the direction of the movement. When they know what is coming, they are less likely to be anxious or confused. Being anxious will make moving and talking more difficult.
But please roll and face toward me.
Sharon told Fred ahead of time what she was about to do with him. Allow time to adjust changes in positions, for example, sitting to standing, lying to sitting, etc. Medications for Parkinson's disease may cause patients to feel lightheaded. Allowing time for changes in positions will make them feel safe. This is especially important early in the morning.
I'll help you sit up. Help push yourself up. Okay, sit and wait a while.
The waiting time is for Fred to get used to the position changes. You may need to lift the resident's legs off the bed if he is unable to do so. If he appears unsteady, you may need to ask him to hold onto the bed rails or you.
I'm going to put a gait belt around you.
Okay.
Always use a gait belt when lifting or transferring a resident. A gait belt makes it easy for you to hold, and it protects the resident from falling. When a resident is wearing a gait belt, they will usually feel more secure to move, and you will feel secure in helping too. Sharon is making sure the gait belt fits snugly and is secure. Set up the placement of their body and limbs so they will be able to safely do as much as possible for themselves. This is one of the most important tips in helping residents. Proper setup of their limbs and body parts can save the effort required by you and your residents in performing daily activities. It may also provide a sense of security and control for them. Fred and Sharon will give us tips during transfers and grooming. Please pay attention to where Sharon places Fred's arms, legs, and body.
I'm going to help you sit up in the wheelchair. All right?
Okay.
Your right side is your strongest side.
Yes.
The placement of Fred's hands, feet, and buttocks are very important in letting Fred participate in the transfer. It is also more efficient to transfer to residents' better functioning side if residents feel a difference between the two sides.
Feet apart. Lean forward, nose over your toes, and help push yourself up.
Sharon did not rush Fred through the movements. Her verbal requests were simple and easy for Fred to follow. Placing Fred's hand on the arm of the chair before transferring made it easy for Fred to move his body forward. If the resident does not get up using this method, you can always use some rocking motions to help. If a resident is very rigid and hard to move through the steps, make sure to allow some time to perform the transfer. You may use a gentle rocking motion. Set up the environment and let them safely do as much as possible for themselves. People with Parkinson's disease usually feel better mid-morning after medication, permitting them to walk better or to dine better. However, they usually need more help toward the late afternoon and evening. It will be easier to set up a dressing routine by placing the clothes where residents can see them and reach in front for them, and by allowing the residents to sit on a chair to do the routine. If residents cannot stand to pull up their pants, you may want to assist them in putting on their pants while they are in bed and then transferring them to a chair or wheelchair to finish dressing. It is also important to remember to dress their rigid side first. Shaving with Fred's elbow on the table will make it easy and less tiring for Fred to do the job. This position will help Fred to do a better job in brushing his teeth and help him not feel tired so quickly. When residents with Parkinson's disease are using the toilet, they can easily fall forward because of their posture. Placing a locked wheelchair in front of them can provide a sense of security, comfort, and help their body to stay up straight. This may ease some of their worries in using the toilet, since residents with Parkinson's disease are often constipated and may take a longer time to use the toilet. Do not leave the residents unattended for extended periods of time. Make sure you are near enough to see and hear the residents when they are finished. A routine toileting schedule is recommended to help keep the residents clean and comfortable. Fred holds onto the handles of the wheelchair to help keep his balance while Sharon pulls up his pants. Eating is important for nutrition, and it is also a time to socialize with other residents and staff members. Begin by positioning the resident correctly at the table. The wheelchair should be pulled up under the table, and the resident needs to be sitting upright with his forearms and elbows supported on the table. If the person wears dentures, make sure these are in prior to mealtime. Also, make sure he is wearing his glasses. If a meal is messy and hard to eat, such as hot cereal, salad, or spaghetti, you may have the resident hold the bowl near his mouth and spoon the food into his mouth.
I'll be around if you need any help.
Allow extra time to perform the task, but make sure you check on their needs frequently. You may need to warm up the meal for them if it takes them a long time to finish eating. When working with a person with Parkinson's disease during mealtime, it's important to be aware of the many different problems that you might see, and also to prepare the food properly for the person. You always want to make sure that the food is cut into bite-sized pieces that will allow them to swallow it much easier. Also, you might see some excessive movement of their arms during eating. This may be caused by a medication side effect. And sometimes the person will not be able to feed themselves, and if that's the case, you might want to take them into their own room or to a small dining room and feed them privately for a little bit more dignity. Also, some of the things you might want to do is recommend them to occupational therapy if the resident is being a messy eater or unable to bring their hand to their mouth. There may be some equipment that's available that will help the person. And most importantly, if the person is choking or coughing during mealtime, it's important that the speech therapist see the client in order for them to maybe change the diet texture and make it easier for them to eat. Some residents with Parkinson's disease often have freezing episodes, especially when they go through doorways, narrow paths, or in a small room. Several methods of distraction may be useful when helping them get out of a freeze. You can talk to them, ask them to look at you or things on the wall, and then take them through the movement.
Fred, look at that picture. Isn't that a nice color of blue?
You can put your arm around the resident or put the resident's arm around you in a country western style dancing position.
Can we do our little dance? 1, 2, 1, 2, 1, 2, 1, 2.
And by doing side-to-side rocking movements, keep up the momentum of walking. You may also count out loud to provide a firm and clear rhythm. Counting can help some residents with Parkinson's disease to pick up their feet and overcome freezing. You can drop a non-hazardous item such as a tissue or a washcloth on the floor and let them step over it.
Can you try and step over the tissue?
A contrasting color such as a white tissue on a dark floor works best. You should always come back and pick up the thing you dropped. You probably want to try the first two methods before you use this tip. Sharon and Fred have helped us understand the 7 movement tips. Communicate before action, allow time to adjust position changes, use a gait belt, align their body parts, set up the environment, allow time to perform, and use distraction to resolve a freeze. Here are some other things to help you when working with a person with Parkinson's disease. Using rails, using a walker to assist with balance, wearing non-skid slippers, use safety grab bars in the bath or shower room, and using adaptive equipment. Some of the adaptive equipment may include a long-handled reacher, sponges, shoehorn, enlarged handled spoon and fork, a plate with a plate guard, or a divided plate. There are also adaptive cups and a toothbrush with a built-up handle. The resident with Parkinson's disease may benefit from an occupational therapy evaluation as well as a physical therapy evaluation if they're having difficulty performing their daily activities or ambulating. And also remember, if a person has difficulty swallowing or chewing, that you may need to refer that person for a speech therapy evaluation. And it's also good to keep in mind that the person is going to have excessive movements, possibly due to medication side effect, and also that they may be able to do something 1 minute and then maybe not in the next hour or the next day. They might not be able to do something. And it's a good idea if you can tell the nurses when you see sudden changes, and to remember that this is a team approach that when we're working with a person with Parkinson's disease, and to remember that there's other disciplines and the nurse and the doctor need to be notified in case there are some changes.